This is Entrustable Professional Activities and Entrustment Decision Making 101, a brief introduction to EPAs. To start with competency based medical education, this movement in the 21st century, broad movement, led to the creation of EPAs. The purpose of competency based medical education is to create a better, broader, more specific standards for physician competence, leading to a move from assuming competence at the end of training to really assessing competence, and to license physicians and register specialists not only when they have completed training, but really when they meet standards based on competence. Uh, this picture shows two dominant models, ACGME and ChenMeds, for competency-based education. This is an example of competency-based education. What you can see on this slide is data from a progress test that was administered to Dutch radiology residents between 2005 and 2009, a mandatory test that every resident takes every 6 months. And you can see that over time, between postgraduate year 1 and postgraduate year 5, their knowledge increases. When the radiologist decided to move to competency-based education, they said, no longer is this test only mandatory. Now the residents will have to pass the test too. And they set a very reasonable cutoff point that actually most of the 4th and 5th year radiology residents would easily pass. And the reason to do that is that they found it no longer acceptable that around 10% of the radiologists at the end of training would not pass this test. Competency-based medical education has been well received in most countries, actually, that use that in the world. But there's also some discussion around those competency frameworks. The frameworks can become pretty analytical and detailed. Competencies are sometimes rather abstract and general, and clinical teachers often struggle with assessment of competence. And as you can see, there's a history of competency-based education. And that led to the idea of introducing entrustable professional activities. Entrustable professional activities are units of professional practice. You can think of them as tasks or bundles of tasks that may be entrusted to a learner to execute unsupervised once he or she has demonstrated the required competence. And that's a shift of focus, a shift from individual competencies to a focus on the work that must be done. And EPAs integrate all necessary competencies. The word EPA includes the word entrustable, which means that the acts that we're talking about require trust by colleagues, patients, and publics. They are professional. They're confined to occupationals with an extraordinary qualification and right, and they are really activities, tasks that must be done. So EPAs ground competencies in daily practice. To look at the difference between competencies and EPAs, think of competencies as descriptors of individuals. A person can be competent. And an EPA is a descriptor of work. They're a unit of work. They're the things that must be done. So EPAs are work descriptors, essential units of professional practice, whereas competencies are things like knowledge, skills, attitudes, values, abilities. And if you look at the Oxford Dictionary, competencies are defined as the ability to do something successfully or efficiently. And EPAs then are that something that is being done or trusted to be done successfully or efficiently. You can think of EPAs and competencies as a two-dimensional grid that actually shows training in healthcare. Think of EPAs like activities that really almost always draw on multiple competencies, different things that happen at the same time in an integrated fashion. An EPA draws on medical knowledge or collaboration skills or health advocacy skills at the same time. And it's actually pretty natural to think of EPAs as a focus of assessment rather than separate competencies that are not easily evaluated separately. But if you have a program that is actually covered by all the EPAs that you have defined, then you can assume that people really have the competencies that are needed for those EPAs if the learners have shown that they actually execute those EPAs well. This shows the growth of competence over time. And if you superimpose that a framework from the psychologists Dreyfus and Dreyfus, you can see that they actually distinguish 5 developmental stages, the middle of which is called competent. And what you can see actually that there is a moment in training that persons are competent, and you could actually say that at that moment they're ready for unsupervised practice. And if you see this as one EPA, you could just imagine there could be another EPA that the learner progresses faster because the EPAs is simply easier. Or there's an EPA that has not been trained until the 2nd year of training, or another very easy EPA. And if you draw that same threshold line of competence, from which moment on you would say this person is ready for unsupervised practice, those moments in training can be very different moments. It could be something that's easy, and actually you would be able to say in a 2nd year resident or even a senior medical student, you are now ready to do this without supervision, whereas more complex EPAs that would only be much later. But so there could be different moments for justified entrustment decisions. And after that decision, which actually, again, is a threshold for unsupervised practice, then you could see that people keep practicing and then become more and more skilled and reach high levels of proficiency. There could also be an EPA that is not practiced after a decision to let them do that without supervision. And if you don't practice, and it's a critical EPA, maybe there should be a moment of loss of trust that we would actually not trust that person anymore with that EPA. So entrustment decisions not only distinguish the dichotomy of supervised or unsupervised. We use 5 levels of supervision, reflecting increasing trust in the trainee's autonomy. From level 1, that we say to a learner, early medical student, you're allowed to be present in the healthcare space, but not permitted to enact an EPA. 2nd level would be, you're allowed to enact this EPA with proactive supervision, actually in the space, in the room, available to take over if needed. Level 3 would be to practice that EPA with indirect supervision, reactive supervision, with a supervisor not in the room, but available if needed. And that threshold then is actually defined as the moment that the learner is ready for unsupervised practice, with not a supervisor directly available, but at most distant oversight. And there might be a 5th level that the learner has progressed so far that this person is actually ready to supervise junior learners. And if you translate that for different EPAs to a curriculum, you can just imagine that an EPA-based curriculum would be individualized, where you would look at different EPAs across a period of time. In this program with 4 postgraduate years, there could be different moments that people actually reach that level 4, ready to act unsupervised under clinical oversight only. And that is basically the framework for EPAs. If you would look at the recommended full description of EPAs, I'd like to refer you to an AMI guide that's recently published that includes the description in 8 sections, a title of the EPA, a specification so that everybody knows exactly what this EPA is about, and maybe limitations too, that you would say if we would decide, make an entrustment decision for unsupervised practice, it might not include the most critical cases. Then there's potential risks in case of failure. It's good to think about that before you make that decision. And then there's most relevant domains of competence and to arrive at a grid that may assist in the way you would evaluate a learner. And then there's required knowledge, skills, attitudes, and experiences that you actually assume people would have before they would be trusted to do this alone. And information sources to assess progress and to support summative entrustment is actually the operationalization of the assessment of the learner. Then there's the question, at which level of entrustment supervision is expected at which stage of training? Usually we say for undergraduate medical training that is up to level 3, which is indirect supervision, and for postgraduate training, of course, that's level 4, unsupervised practice. And there might even be a time period to expiration if the EPA is never practiced. Now, if we go more in detail on entrustment decision making, we have to look at how does that actually differ from the regular workplace-based assessment. We're moving from just assessment of ability to that entrustment decision making. I have to realize that the traditional psychometrics do not work well in the workplace. We know from generalizability studies that the variance caused by raters and context is larger than the variance caused by trainee qualities, and that is usually worsened by a lack of supervision, fragmented care, short patient stays, little observation, and short rotations. And there is often a general lack of mindset to avoid a failure to fail score. A move from traditional assessment to entrustment decision for EPAs may increase the validity. And that is because we align the construct of assessment with the construct of patient care in the assessment of learners. What we do is actually bring the patient into the assessment equation. For instance, in anesthesiology, an important question for an educator is, can I leave the operation theater? And that leads to a more reliable workplace-based assessment. In a study that compared the 9-point entrustment skill that Jennifer Weller developed related to the regular 9-point mini-CX skill, she found actually that the variance due to the trainee increased substantially, whereas the variance due to the raters decreased. Now, if you think of the trust concept in EPA-based assessment, we have to realize that trusting someone is making yourself vulnerable. It is making a calculated risk that adverse events are now acceptable. Have to realize too that graduates will be certified to carry out activities that supervisors may not have been able to observe, and sometimes even learners may never have encountered. So entrustment decisions require some sort of estimation of adaptive competence to cope with unfamiliar situations. So before we go more in detail, I need to make that distinction between ad hoc decisions of entrustment and summative decisions. Ad hoc decisions occur in the daily routine of clinical practice, whereas summative decisions of entrustment are made by teams and based on multiple workplace-based assessments that have been evaluated, and they focus on an increased autonomy, sometimes called a STAR certification, Statement of Awarded Responsibility. So what factors actually determine entrustment decisions? Just imagine this situation. Here's a clinical teacher actually determining whether this learner can be trusted, but thinking by himself, I can I trust this student to attend to this patient now? And we have to realize that it's more than knowledge or specific skill and proficiency that is at stake. This is an example of an ad hoc entrustment decision. And if you think of that same sentence, there's many elements in that sentence. Can I trust this student to attend to this patient now? We know from the literature there's 5 groups of variables that actually determine whether that decision is made. It is the trainee, it is the supervisor, the task, the context, and the supervisor-trainee relationship. So if you think of the trainee, it is things like integrity, reliability, humility, capability, and agency that are important, and I'll come back to that later. And of course, there is a learning need. Then there's the supervisor with clinical experience, with clinical ability, trust propensity, supervisor experience at all determine whether that supervisor will make that decision. Then there's a task, and the difficulty of the task or the risks that are involved also determine that decision. And then there's context, how many qualified personnel is around to help if needed, or the time of the day, or the need for hands, that all come to that equation of determining whether that entrustment ad hoc decision will be made. And there's a supervisor-trainee relationship. Is there a like-mindedness? Do people understand each other quickly? What is the duration of the acquaintance? What is the interpersonal culture at the ward? So there's general qualities that enable trust in trainees to come back to the trainee. And we know from several studies, studies that were actually focusing on what do clinical teachers find important when they make an entrustment decision. And we found actually 5 groups of factors. One is capability. That's the specific knowledge and skill for that EPA, experience with it, awareness and oversight. Then there's general integrity. It is truthfulness. It is, does the student have good intentions with, and is the student patient-centered? Then there's reliability, which means, is there a conscientious behavior? Is the student predictable, accountable, and responsible? Then there's humility, which means, is this student observing their own limitations? Is the student willing to ask for help? Is the student receptive to feedback? And then there's agency. Does the student show self-confidence? Is the student proactive towards work, toward team, toward patient safety, and toward their own development? And if you juggle the words, the first letters of the words around, you arrive at a useful acronym. Think of a rich entrustment decision. Now we make important decisions. The most important decision is at the end of training. Are we licensing this learner? Is this learner ready to complete training? Or are we certifying a specialist to start working completely unsupervised? And there's two ways of thinking, two perspectives. There is a retrospective view and a prospective view. The retrospective view basically says, has the student mastered all the content that was taught in courses and rotations? Did the student actually respond to the demands that we actually set for the student? The prospective view, however, is this student now ready to assume the expected future responsibilities? Which is actually a different question. If we think of the pyramid of Miller, and most of you will recognize this pyramid, the highest level may not be, does the student do well on the clinical ward, but is the student ready for tomorrow's care? Found that pyramid, and we build it. We all know that the nose level is about knowledge. The knows-how level is about applied knowledge. The shows-how level is about integrated knowledge and skills. The does level is actually the knowledge, skills, and attitude integrated and observed in context. But the highest level is the estimated readiness for future demands. Now, to get practical, the flow of workplace-based assessment data is like this. There's multiple times that an ad hoc decision with an EPA is being observed. And when evaluated, the learner receives feedback and can have a new attempt at that same activity, and enough attempts until the student does well. And meanwhile, if the learner has a portfolio, every observation can feed into that learner portfolio. When the learner is ready for a summative entrustment decision, then that request goes to a clinical competency committee, or sometimes called an entrustment committee, that receives that request, evaluates it for a summative entrustment decision, drawing on the data from the portfolio. And the conclusion may be that this student now is ready for a statement of awarded responsibility. Now, this whole developmental process of growth of competence for an EPA may also be viewed as growth of autonomy and decrease of supervision, from observation only via phases of direct and indirect supervision to readiness for unsupervised practice, or distant supervision if training is not yet completed. Every transition can have an explicit or implicit entrustment decision, but the biggest one, of course, is the decision for unsupervised practice. In this example, the learner has the opportunity to experience what it is to have all responsibility before the end of training, just like how it will be after leaving the program and starting to work elsewhere. To wrap up, in competency-based medical education, all graduates should meet standards of proficiency. Competency frameworks such as CANMEDS or ACGME can benefit from EPAs to make the link with daily clinical practice. And EPAs then are units of practice, while competencies are features of individuals. EPAs and the 5 levels of supervision create individualized workplace curricula, and entrustment decisions focus on the readiness for future responsibility and require capability, but also humility, integrity, reliability, and agency. And a gradual increase of autonomy serves both competence and patient safety. Thank you for your attention.